In this module, we will discuss the significant anatomic locations for the administration of successful local anesthesia. The most important criteria for successful administration of local anesthesia is an understanding of the pathway of travel of the nerves we are trying to anesthetize. These nerves all travel in tandem with major blood vessels, which we must be mindful of in order to avoid complications. Since we can't actually see or palpate the nerves, we are trying to anesthetize by identifying the bony structures that these nerves approximate and the foramens they exit. Therefore, our objectives are to be able to identify the routes of the nerves relevant to local anesthesia, as well as identify the key osseous structures which will aid us in these locations. We must also be able to describe and locate the soft tissue structures which will help us find our entry points and guide us to our targets. Here we see a frontal view of the human skull with a very interesting spelling to skull. The significant landmarks in the maxillary arch include the canine eminence, the canine fossa, the alveolar process, which is the bone which surrounds the maxillary teeth, and the zygomatic process. Often, the target of maxillary local anesthesia are the apices of the maxillary teeth, which can often be palpated. The trigeminal nerve has three branches. The first branch is V1, the ophthalmic. It is sensory in nature and supplies the forehead, the eye, the skin around the eye, the eyeball, and in local dental anesthesia is usually not an appropriate target. The second branch of the trigeminal nerve is quite important in dentistry and is V2, or the maxillary division. It is responsible for the hard palate, the buccal tissue, the pulps of all of the teeth, the soft palate, and plays a critical role in successful local dental anesthesia. The third division of the trigeminal nerve, or V3, is the mandibular division, and it is the only division with both a sensory and motor function. The sensory functions are listed on the left, and the motor functions are listed on the right of this slide. Next, we will discuss significant maxillary anatomy. Here we see a lateral view of the maxilla. Please note the location of the posterior superior alveolar, the middle superior alveolar, and the anterior superior alveolar nerve. These are all targets for our local anesthesia. The proximity of the anterior superior alveolar nerve to the infraorbital nerve should be noted. In review, maxillary bone covers the facial surface of the maxillary teeth and is much less dense than the mandible. It's critical to understand this as it provides the rationale for the higher success rate for maxillary anesthesia. The median palatine raphe is a landmark for the anterior middle superior alveolar block, and it is the midline of the palate. The incisive foramen carries the branches of the right and left nasopalatine nerve and is the landmark for the nasopalatine injection. The maxillary tuberosity is a landmark for the greater The greater palatine foramen is a landmark for the greater palatine block and is located in the maxilla in a medial lateral direction halfway between the mid-palatal suture and the margin of the palatal teeth. The mental foramen is a landmark for the mental incisive block, and the coronoid notch is one of the three landmarks for the inferior alveolar. The mandibular foramen is our target for the inferior alveolar block, but cannot be palpated. The medial superior alveolar nerve is only present in approximately 28% of the population. The, the medial superior alveolar nerve supplies the pulps of the premolar teeth, the mesial buccal root of the first molar, and the accompanying buccal tissue. The long buccal nerve is a sensory nerve that, for dental purposes, anesthetizes the buccal tissue of the molar teeth. The lingual nerve is in close proximity to the location of our target for the inferior nerve and is often anesthetized at the same time as an inferior alveolar block. The mental foramen serves as the exit point for the mental nerve and is a sensory nerve for the chin, lower lip, and labial mucosa of the mandibular anterior teeth. The other branch of the mandibular nerve continues within the body of the mandible and supplies the pulps of the mandibular anterior teeth and the first premolar. Because the facial nerve passes into the parotid salivary glands, an inferior alveolar block, which is too posterior, may inadvertently anesthetize this nerve and result in transient facial paralysis. Posterior superior alveolar blocks are in close proximity to the pterygoid plexus, and posterior superior alveolar injections, which are too posterior, may nick this plexus and result in a significant hematoma.